All right, so thank you all for joining us for the roundtable today. And so we're going to start very quick and easy with, where are you seeing the greatest tension or synergy between quality metrics and risk adjustment programs right now for you guys? Mark, you want to start?
Goodness. All right. That's a great question. So, a little bit of it had to do with disparate ownership. So, think of quality and stars for that matter through typically a more clinical lens. In reality, it is numerical and quantifiable at the end state. So realizing that there's a ton of clinical things that need to occur owned by disparate teams to be successful, none of them really took ownership in the quantifiable outcome, the stars rating, the quality metrics. So we acknowledge that, living in a different team, and then risk adjustment, which has been very much seen as a tool of revenue defense, utilization acknowledgement, in a very actuarial, data-driven and reporting sense. Now, risk adjustment is getting a tremendous amount of regulatory and compliance pressure from every single government agency and every single congressperson that is making a name for themselves. So seeing a lot of pressure there is really putting a ceiling on what has historically been seen as an opportunity for health plans. So recognizing through quality that you will win always delivering good quality, putting that first and then watching the STARS score and the risk adjustment come later has been a seismic shift for our organization. So we have brought them all under one team, which is now the team that I lead. We call it SQUARE, STARS, Quality, and Risk Adjustment, and in that order on purpose. So that's what we're seeing. The other thing is a tremendous amount of pressure from shiny objects. And we have not found, no offense to the innovation people, I think you're all selling us shiny objects all day today. But we need to see those really make lives easier and acknowledge that they are not always cheaper, but they need to be better and alleviate some other concern, because someone's going to catch the outcome of that AI ball, and they have to be ready for it and willing, for that matter. So.
Perfect. Joon, I know with it being a new program for you guys, how are you seeing that for Champion?
Yeah, for Champion, in terms of on the annual wellness visit side, you have this kind of mode to which you can, or medium to which HCCs can be captured. So you analyze the chronic conditions and the.
I don't think that mic's working.
No, it's for the podcast.
So I think the aspect of really leveraging it, the annual wellness visits as that mode to be able to correctly characterize the complexity of the patient population is really important. And in that, with the HCCs, the other thing that I mentioned, which kind of philosophically is, it's a group assignment. So many times people look at individual providers and they'll say, this provider is doing really well, this one's not so much, and what gets failed to be realized is that it is a group project, meaning that if you're at 100, I'm at 50, and we as a group, we reflect 75, that's what it looks like. And so the group dynamic is really composed of not only your best and worst, but how do you pivot and strategize to kind of streamline so that it can be better as a group. So if he's at 100, I'm at 50, maybe I need a little more runway to learn and practice. And in the meantime, what can happen? Maybe he's the one taking on both sides of the patient population, and then now we're at 100. So it gives me some time. I think those are the pressure points that and the synergies that can be levered that people haven't really thought about. And a lot of groups, they just keep going at it as, let me just hammer on the individual person that's not doing really well. And on the quality star side, I think there's an aspect of how do you streamline the effort? Because one of the biggest challenges is there's so much outreach that's being done. And so even within organizations, if they're not really organized, they look at kind of a laundry list of to-dos. And now I've called the same person 3 times because they were on my hemoglobin A1C list, they're on my breast cancer list, and there's a certain amount of fatigue that happens at the patient level. So I think we're seeing that, and how do we package it? And so, great app like Innovator would help. And then probably the third thing that I see in the industry, in the just kind of in the population, is a lot of fatigue. There's a lot of fatigue around just kind of getting calls, mailers, so on and so forth. Whereas, 10 years ago, you send out a mailer and someone will respond because they see that it's important. It's important. It's from my provider. It's from my health plan. Now, it's really falling on deaf ears. So I think there has to be a paradigm shift on what will we do to get connected and get members and patients engaged.
I mean, if you look at the way quality measures are structured today, they've not kept up with the times. So many things have changed. There are, new high-cost drugs are coming into picture. We just went through a big epidemic, right? Mm-hmm. And none of the measures have been tweaked to help manage their population for those things. Because we seem to think, and of course, CMS is 3 years behind, right? Mm-hmm. So by the time they get to it, we've taken AI and done something completely different. And talking to CMI or any of those innovation, that's so late in terms of how it comes to the marketplace. They're trying to do something with ACO reach and everything else. How effective is that going to be is something that they are going to evaluate. And then they're going to say, okay, we'll continue this program for the next 2 years or 3 years. How do you expect organizations to invest in a Galaxy-type platform, which takes a few months to a few years to see ROI, while somebody pulls the rug from under your feet because somebody else sitting in Washington, D.C. thinks, oh, we should be doing this, because that's what the model told us. The models were late. So bringing quality and risk adjustment together, star scores together, should focus more on a particular patient population, a particular demographic, and because not every 65-year-old is the same, and not every 85-year-old is the same as well. I see both in our populations, 85-year-old more than the 65-year-old. 65-year-olds are more behavioral, 85-year-olds are more acute, sick. So the challenge is, how do we make sure that we bring it together in a way that's meaningful for the patient and it's meaningful for value-based care? That's where I think there's value.
What new measures do you think that they should be putting in place?
So if you look at it, right, I mean, can we drive measures based on populations? For a behavioral health population, what are the measures you got to look at? Don't tell me, go speak to them and ask them to fill out a document and saying how good am I, PHQ 9. Okay, who the heck cares? They're already behavioral health. Why are you doing the same thing? Makes no sense. Now take about another patient who's suffering from chronic kidney disease. You're asking the same questions for the guy who's chronic kidney disease. He's on dialysis every second day. That same measure is not going to work. It's a different measure. It's a different process. And we talk about, chronic disease management, but the measures are not based on chronic disease management. The measures is based on population. Now, population could be anywhere between very healthy to somebody who is sick and dying. So how do we make sure that you are stratifying for the population? And then you have to go through exclusions, right? They give you exclusions. Okay, if you're on hospice, you don't have to do this. If you're on about 65, if you're on an institution, great. But then by the time we go through all this stuff, it's like a nightmare.
So Matthew, looking at this, what do you think are the barriers that are really keeping you guys from being able to get those measures and being able to get the member engagement there for outreach initiatives there that Joon had mentioned?
So I would say, first of all, just briefly going back to the risk adjustment quality discussion, I would say our plan is right now a poster child for siloing. So for instance, I am strictly over the quality and the star side, whereas of course we have a separate department that works with a separate vendor for risk adjustment. So obviously to me, that's one of the first barriers that we encounter, is that obviously we know that there's lots of great data on the risk adjustment side that we're just simply not aware of because of that siloing. So I definitely think just being able to work more closely with that risk adjustment team, but more importantly, working in the same platform. So obviously, because we're on separate vendors, we're also in separate platforms, and we have separate teams that speak different languages, different acronyms. So I think really what I would love to see is obviously the same platform for both sides, but also being able to really bring our SMEs together and then really just have that cross-training, that understanding of, on our side for HEDIS, we're speaking to these exclusions, these technical requirements, whereas on your side, you have to code in a certain way. We know that certain things are going to get rejected by CMS. So really, we know that at the end of the day, we're working with the same data. We're ingesting the exact same data, obviously the same records across the board. So if we can just have the same platform, same level of understanding, and really that expertise across the board working together, I think that's one of our biggest barriers to overcome.
And Jim, with regards to pharmacy?
So, I feel like I should give a little background here because I live in a different world. So I represent a PSAO with Cencora. We work with 5,400 independent pharmacies. What we really struggle with is the pharmacies being aware of focus points to drive quality performance, to engage the patients. I would be happy with siloing, by the way, because that world doesn't exist for me. It's just making sure that the pharmacies have the knowledge, the engagement with our vendor partners like Equip to correctly engage the patients where appropriate to drive health outcomes. And it's a continual process, and it's not one that I see being rectified in the near future. We are seeing technology advancements with some prompting technology that really fits into the pharmacy workflow and allows them to address the patients without needing or seeing fragmentations in systems or logging into different systems, but it's a work in progress. So a little bit of different environment, but one with plenty of opportunity. So.
And Jim, I think what you're maybe illustrating is you're the last person at the chain of things, right?
Absolutely.
Like we have these huge AI models, all these shiny objects, all these people that are making it faster and easier to contact members and to drive different care avenues. At the end of the day, someone's at the end of that chain and receiving everything. So you're getting med adherence, you're getting fill times, you're getting immunizations now, I imagine, can happen within a pharmacy.
Yeah, and to your point,
across a litany of all these different vendors, and there's no conformity, and you're the one that's catching all these things coming at you.
Yeah, the common response that our team gets from our pharmacies is, where do I start? This is overwhelming. What's impactful to my patients? What's impactful to my business? And they just don't know how to make heads or tails of it. So there's a lot of opportunity for clarification there.
So it's interesting, you keep talking about shining objects.
Yes.
I had this conversation with our CFO, and he's like, so what's wrong with shining objects? Gold is at $5,000. What are you talking about?
Silver's at 90. Yeah.
So, I mean, it's interesting that we talk about this stuff, but it's also, there is so many tools out there in the marketplace that we get bombarded with a lot of stuff right now, and everything has got a .ai behind it, no doubt. So the question is, what problem are we trying to solve? Then we go after a solution that not just solves one problem at a time, but solves a multitude of problems at a time. So you understand your data, you figure out a framework that you can use that data, and you figure out how to bring in the data for not just, okay, I need to go to this, like what you're talking about. Oh, for risk analysis, I'm going to go to X. For Q, I'm going to Y. And then, oh my God, my finance guys need this, so I'm going here. By the time you got all these technologies, I sit on the cusp between technology and operations. So when you're looking at technology side, it's great. I'm very happy because, I get a long, lengthy life, right? I don't need to worry about, because more technologies, the technology guys are happy. But guess what? From the operations side, by the time you take care of all of this stuff, it becomes very difficult to manage, and you get a lot of questions. Because they use one data uses this way, I run the same data, I get a different analysis, and then you have conflicts. Is this right or that is right? Is that tool that is coming from there right, or is the tool right? Now you're questioning not the people, you're questioning the tools, and now you're questioning yourself. Should we be doing this way? And it becomes difficult.
I'm really interested to kind of add on to the pharmacy discussion. So my background is more so on the operations of pharmacy. So we definitely understand the struggles with the PSAOs and pharmacy trying to close all these gaps. I think for sure we oftentimes take advantage of the fact that obviously the pharmacy is the last mile for the member, where, like you said, we're trying to close so many gaps, just pushing on the pharmacies, trying to just do that since that's one of the best opportunities outside the doctor's office. But really, I would say a lot of what we've learned is I think we also just take advantage of that by we're so heavily focused on VBC arrangements with provider services, provider offices, that really there's a lot of opportunity we just haven't explored with having that same type of structure with PSAOs, with the pharmacy side, since we're looking to y'all for so much and trying to close so many gaps, and it's just getting worse with more and more Part D measures coming down the pipeline.
Yeah, I couldn't agree with you more on the value-based care side. I mean, and it's something that I know that my PSAO has an interest in. We're really focused right now on how do we continue to develop technologies and tools, going back to my previous comments about getting them engaged. If we can do that, that's definitely an avenue that we want to explore. And how do we support value-based care? What's the leverage that we have as a PSAO with our member pharmacies?
What cross-functional collaborations do you think have been working, and which ones would you like to see expanded more with the ones that you have accomplished?
Cross-functional collaborations that have been working for
For the pharmacies and the physicians, which ones have you seen
Oh.
that have worked?
For pharmacies and physicians, I would say on a limited basis. Part of the challenge there is in dealing with the pharmacies, dealing with an owner that's focused on dispensing. They are not good. Most of them are not good with provider relationships. That right there is the first challenge, is how do we get them out of their comfort zone and establish a relationship with their local providers to provide best-in-class care. And that alone could be the only focus point. But for those that have those relationships, we see a pharmacy that will continue to develop even further into opportunities that allow for better patient outcomes, better patient care, and potentially revenue for the pharmacies. We've got pharmacies with collaborative practice agreements that have done a great job in fostering those provider relationships, but it's on a limited basis. 90% plus of their revenue is still fill focused, and they're dealing with reimbursement challenges that impact their operations and the ability to operate efficiently. So,
Are you guys providing any incentives to the pharmacies as part of your programs?
So I will say we delved into that briefly. So we did work with one of our local PSAOs a few years ago, and we had for that 1 year, basically an incentive structure, not a surprise, working around medication adherence, primarily the statin-based measures. I would say we saw some promising results with that, but I think from lessons learned, going back to your point, we realized that we can't just push a bunch of reports onto the pharmacies and expect them to close the gaps. Obviously, we have to have that additional level of training and understanding for exactly what we're addressing and how this fits into our broader picture. I think the other thing, too, is just we've learned a lot about conflicting priorities or conflicting end goals. So obviously, on our side, we constantly push for 90-day fills because we think that's going to close more gaps. But then recently, in the last few years, we know that, especially for independent pharmacies, they really struggle a lot because they lose that extra dispensing fee. Mm-hmm. To your point, now with a lot of these reimbursements like GLP-1s really taking a dive, putting more financial pressure on them, I think that was a lesson for us that we could have seen a lot better outcomes if we just came to the table really understanding what those competing priorities were and how we can address them at the start.
I think the other aspect of not only the competing priorities is that going back to kind of the amount of items that are placed upon the provider groups, right? So you got the pharmacy list, and now that's one set. You got the ATCs, that's another set. You got the quality pieces, that's another set. And I think the hardest part is, at least from what I've seen in the landscape, is that you have the have and have-nots. So you have those that are larger, those that have a lot more resources, those that may have IT or other type of infrastructure. They're able to deal with all these pieces and kind of package it together and streamline it and take care of the providers in that sense. For those that are smaller mom and pop, that just falls on them. And what we've seen is that they're, even in the bigger organizations, I've been part of big organizations, and we have a lot of providers that have experienced burnout because they feel like they're getting pulled a multitude of ways, and all it is they're left holding the bag. So having said that, I think that going back to the commentary about the list of quality items, do we have the right set? And I know that now I'm starting to dabble into kind of things that we cannot control, which ends up being longer term kind of policies. But I'll make the comment, chronic conditions, if you have an amputated foot, why do you have to capture that every year? It seems like there's an amount of documentation just jumping through the hoops that's somewhat unnecessary. And I think if we really want to focus in on making an impact on the members and the population, then we should make things a little bit easier or a lot easier and not so difficult. Because right now that's what it feels like, is we're just adding more and more, add something new, and then we don't provide resources. If there's a new group, we don't provide like initial startup. There's no seed money. It's everyone just kind of has to bear it on themselves. So I feel for the provider groups that are kind of coming into the space and wanting to do it well, but they don't have the support to do it.
Just really quick on that, Joon. It is on everyone in the room to share this feedback with CMS too. CMS does listen to us, so I 100% agree with you, and I've shared that every single year that we do not need to constantly be recapturing these chronic conditions on an annual basis, and it is a waste of time, especially for the amputation reference. So please, everyone, share that feedback, especially during the season of the year with your CMS representation.
And it's interesting, we spoke to CMS about it, right? CMS takes into consideration what we tell them, no doubt. The challenge for them is how quickly can they implement stuff through their processes. And we struggled with that piece for quite some time. We said it takes them between 2.5 to 3 years for any policy change to occur, assuming no administration changes, right? Every 4 years you have that too.
Yep.
So going through this process and identifying the changes first, because it takes a while for us to do the analysis and provide the feedback. They're like, oh, great, this seems to be, what you guys are saying is right. And then we will look at it and we will make changes. And then they go around and talk to, every
There's a
power,
shutdown.
everybody else, right? And then go, okay, yes, we can do this, right? That makes sense. But by the time it's done, it's like 3 years have passed. And, in our case, I mentioned it before, in our case, we lose, 3% of patients monthly to death. So by the time the patient gets the benefit, the patient's already dead and gone. So how do we help that kind of, so that's why I said, right, it doesn't work for everybody. And to tell you the truth, frankly, chronic care management is a huge issue. Because people just assume that if you have a particular condition and you report the condition, you're done. No, the condition worsens in some cases. And how are you going to capture that in a more detailed way in order to get the appropriate risk adjustment?
Well, and even taking into consideration when you do document it, CMS is now coming back 7 years later to do the RADVs, and we're now catching up on the RADVs. How is that impacting all of you guys right now with the RADVs? I mean, you've got providers who are no longer in the market. You can't find the documentation. How do you maintain compliance?
Forget the providers, the patients are no longer in the
There's that as well.
around.
This is, Michelle, that's such a great question. We did 5 RADVs in the last 12 months. We plan for 36 more RADVs in the next 4 years. And I'll tell you, the things we witness is amazing. Like, we have providers that have gone to jail. Can we get their attestation from a jail cell? We have providers that we had to send in a hardship exemption for with an obituary because they were no longer with us. We had providers that burned their medical records on a beach in North Carolina when they retired and live in an RV. This is just scratching the surface, right? But all along the way, the results of this RADV is extrapolated across my entire book of revenue. And I have hundreds of millions of dollars of exposure for something completely outside of my control. So absolutely, RADV guidance is the number one thing that we pontificate for. It has to change. We have the industry's best exception rates of around 95%. So 5%, and it's all people where we cannot find the medical records. So I know CMS went for this big land grab of the evil health plans. I haven't seen anyone that works at them quite yet here, but I got to watch where I'm looking. That have really done a great job of optimizing this through the use of in-home risk assessments. They're not finding it. It's a big nothing sandwich for them. And when they do, it gets so locked up in litigation that it's kind of like everyone's just wasting their time. So the red fee question is striking a little bit of a nerve. I'd love to talk to anyone about it over cocktails.
Happy to discuss it. It's one of my favorite topics.
Oh, yeah, sure. So I think, back to the agenda of the speaking points, I think one thing is that has to be part of every single one of these vendor solutions, is easy access to things that can make the audit trail better for everyone. That means not going back to the provider, not having to use AI or a coder as eyes or anything. It has to be very simple for us to use and to do. And that's part of table stakes going forward.
I mean, that is, I think, assumed to happen.
Yeah.
Right? It's no longer like, will it happen? It's like, okay, it's going to happen. What is the vendor going to do to help you get there faster? And how are you going to make sure the data is there to make it work? I think that concept, that's why I'm like, the shiny object that is what I want. That is the kind of stuff that I'm looking for, but I'm not going to 6 vendors to go get it. I want the vendor who delivers to me that as well, so I don't have to go and reinvent the wheel every time, which is what we tend to do. I mean, health plans still are so archaic, even the big ones. Ask them to give you a member demographic report. Oh my God, they can't give it to me. I mean, that's how simple it is. But that's healthcare. Can't change. It's going to take some time to change.
With those barriers, what do you think has been the barrier for adoption within the organization? Well, your departments want to move. What are the barriers outside that your control that you are working and fighting every day on?
So barriers is, the other thing is, we keep pushing data in front of clinicians, right? And they are, instead of pushing back, they just say, this is too much, we don't want to work here. We've seen that a few times. Some are incentivized to do it right. Yes, I understand it. But some are like, I think this is beyond what we could do in this kind of environment. So we're just going to go, can't do it anymore kind of situation. And then there is, we have incentives, we have programs, we have plans, we have coaching, we have education, training, you name it, everything possible, we know we have. But at the end of the day, every time when something changes, you're now, kind of what I call sending the change downstream, and as and more you change downstream, it becomes very difficult for that clinician to understand it and then act upon it. By the time they understand it and act upon it, something else happens. So it's constant. That's the difference. That's the difficulty.
One other thing that I think about in terms of it's a headwind, and there's been legislation that says it should be happening, but yet there hasn't been a lot of traction, or there's been a lot of pushback or dragging of feet is around data interoperability. Mm-hmm. So the ability for us to say, look, that HCC was captured somewhere, there's supporting documentation somewhere, that that colonoscopy was identified somewhere. Well, why can't we get that somewhere? And I think the amount of the inability to actually have true data interoperability is stifling us as an industry. So I think that's kind of a wish list. That's a huge barrier. Mm-hmm. And so I think whether it's supporting an audit and taking accountability, whether it's moving forward on items that we need to take care of for the member, or to better analyze just kind of the population and where we're at, we need the data. And so I know that, Larry, I think it is Larry Ellison, the CEO for Oracle. Mm-hmm. He has a desire, and I think others have, of kind of stitching together, your whole lifeline of healthcare information and having that just shared throughout. Mm-hmm. And I think that would be tremendously helpful.
If I could, just really fast, on that one, June, I think the rules and the laws and the threats that CMS and the regulators make against us in terms of HIPAA compliance are working against them in our outcomes. They is so damning and so salacious in terms of data breaches and the amount of insurance we have to carry to restrict us from working together on data interchange. It's like sometimes such a nightmare that by the time you figure it out, the opportunity has left you. So that's another barrier that could maybe easily be removed is if we could get rid of some of that anxiety around the fear of a HIPAA compliant breach or something. Like no one wants our health information leaked. Like of course not. That's near and dear to me. But ultimately I also don't want to pay a shit ton for insurance either. So like we have to find that balance as an industry and maybe give up some of that control and accept some of the risk without the penalties of that could exist out there.
Yeah, not that it's exactly the same, but for me, I'll speak in the I. My banking information, my money is important in terms of just kind of keeping that secure. But yet I can go to an ATM and withdraw money from different, so they've figured it out. All around the world. But yet on healthcare, we're so, tippy-toeing around a bunch of stuff. I don't think the solution is a problem. I think it's just having the commitment to do it. And then I do think that there's big organizations that are dragging their feet around sharing data, and that needs to change.
Yeah, I would just say going back to the barriers, speaking from the quality side, I think a lot of what's helped us get buy-in from senior management or other departments. Obviously, the barrier we always run into with new vendors is fear of change.
Yep.
How's this going to impact my workflow? Is this going to impact my job? Will I still have a job? So I think really what's worked well for us lately is really just painting a very clear picture across the board. So for instance, we go to all the stakeholders and we just target to them what they know, their role in this, and how this is going to benefit them. So for instance, with IT, we'll go to them, work closely with them, and just spell out, this is how this will reduce your workflow. This is how this will make life better for you. By not having to have all these headaches and build all these file layouts and certain layouts and back and forth with the vendor. With our team of nurses that go out into the provider offices and gather the records, because we know HEDIS is starting to move so much further away from claims, we really just paint the picture of, look at these measures coming down the board. They're all LOINC codes, SNOMED codes, never going to come across on a claim. We need to invest in this so that we can actually close these gaps. That and just
Can you pay a little bit extra for those codes, maybe?
Yeah, so actually that is a good point too, because for instance, last year, going back to our provider groups, we've really just dipping our toe in the water there is with CPT2 codes. Obviously I like to think of it as somewhere in the middle, whereas we're moving away from a strict, I guess what we call typical claim codes, but we just pay out a very small incentive for the CPT2 codes. So quarterly, the money goes directly to the provider. It doesn't go to the overarching entity. It goes straight to their office. And even though it's not very much, we've seen some really great double-digit growth on just our initial administrative rates, just with that small payout. But yeah, and obviously with the loss of hybrid measures for HEDIS, it's really just painting the picture that in order to make your life easier, better in all these different areas, moving towards this single vendor, this automation, this incorporation of AI just makes the most sense for all of our needs.
Last question for the group. What emerging technologies or policy changes do you believe will be most impactful on the intersection of risk and quality performance over the next 3 years?
Are you talking positive or negative? I don't see any positives. I think that they being CMS is going to put immense pressure on medical record review and home risk assessments as part of the No Upcode Act. And should they make the mistake of cementing that legislation, it would be a monumental headwind. I think great care is delivered in the home. I think you glean amazing insights from home-based care. And I really hope that cooler heads prevail in terms of that, the No Upcode Act. So that's number one on my list. And that's just at the mercy of the pen stroke. So that could be very, as soon as that happens, it's going to be all about the provider care setting. So think of the amount of pressure that pharmacies and clinicians and medical groups are getting from plans and payers and members right now. and amplify that even greater with the removal of those two different options. So I really hope CMS reconsiders.
Jim, your thoughts on that?
I think pharmacies are willing to engage. They obviously deal, going back a little bit to the barrier. Barrier question is workflow, investment in technology are huge factors with the independents. But they also face challenges with scope of practice at the state level and at the federal level. And I think those are two huge factors with regards to their continued involvement, their involvement in providing care in rural settings, pharmacy deserts, outreach in those areas. They want to engage, whether they can because of the workflow, the time, those barriers have to be reduced first.
And I know Shri.
I mean, from what I see, we definitely have to stratify patients and have the right measures for the right patient population. That will be very useful. Second thing is avoid too many policy changes, sometimes irrational, without actually talking to the industry, because some, lawmaker wrote something somewhere, someplace. It is not helpful. And the third thing is, the CMS and everybody else want to talk about AI and new innovation and technologies. Incentivize people to make the right investments in those technologies so they get the better results back. And they have to do the same investment on their side. If they want to share that information with us, and we want to share information with them, we need interoperability with the government.
I think just on the quality side, I would say I'm probably overly optimistic, but just as with interoperability, we were probably all overly optimistic. We'll get to this perfect place. But really for me, I'm optimistic in terms of just the real framework, the shift recently in terms of CMS's push towards the universal foundation measures. I definitely think it's just eye-opening to know, even for seemingly the same measure, in MIPS, in the STARS program for Medicare Advantage, it can be profoundly different in technical specifications, who's in the measure, how to exclude. So obviously just with different tech specs as well as different measures, it's just overwhelming, just as we saw with all the data exchange under interoperability. So even though I know it's going to be very hard to get to that ideal spot, I really just think that's going to be our best option in terms of simplifying, reducing the number of measures, which we know CMS is really considering lately, as well as just making it much more transparent in terms of how we calculate quality and really understanding which measures truly generate the outcomes, the value that we're ultimately looking for.
Yeah, and I'm not sure if it's positive or negative, but I think there's a forced change that I think is really interesting. So I'll give you two. One is around, and I may have gotten this date wrong because it may be that the goalpost has moved, but it used to be 2030. So there was a stake in the ground that all Medicare was moving to a risk-based managed model, and so, which essentially means fee-for-service is going away. And so to me, that's something for providers, all groups within the healthcare industry to kind of anchor to that and say what needs to change, how can I improve, what, and again, could be positive or negative. And just as a side note, on the Medicaid side of the house, they've also put the stake in the ground to encourage 2030, and across the country, a lot of states have adopted managed Medicaid. So those are two things that just the worlds are colliding in toward managed care or value-based care, and I think it's really important for us to keep our heads up with it. And then the other part I am really curious about, again, not positive or negative, but I think is forcing our hand in change is going to be AI. And I think we'll have to figure out like how to play and how to incorporate AI into our space. I I think the image I used to use in a presentation was ostrich with its head in the sand. I'd say don't be the ostrich with its head in the sand, because either way, it's coming. Both of those things are coming.
Perfect. Gentlemen, thank you so much for your time today. We appreciate everybody joining us and participating today, and we'll have some additional breakout sessions throughout the afternoon. So thank you, everyone, and I wish you all a great afternoon.
Thank you, Michelle.